All right, thank you very much, Catherine. So my name is Nick Caruso, and here we have a case report on a hydatid cyst in Kansas. Let's see. Okay, and about me, Catherine kind of touched on all of it. I'm graduating from KCU in about 2 weeks and going down to Rush in Chicago and coming back to UMKC for radiology residency. So hydatid cysts, what are they? They are cysts caused by a tapeworm called Echinococcus. There's several different species, and the one we're most concerned about is cystic echinococcosis, which is caused by Echinococcus granulosus. It typically presents as a single solitary cyst in the liver about 75% of the time. And then it can be found in the brain, bones, and or pretty much anywhere else in the body the rest of the time. There's a second type of echinococcus which affects humans, which is alveolar echinococcosis, which is caused by Echinococcus multilocularis. Typically presents as a multilocular cyst, which is tumor-like and infiltrative. And then these patients there's mortality 90% of the time if they're left untreated. So it can be a very intense infection, but we're talking about the cystic echinococcosis today. Kind of hard to say 10 times fast. So the way cystic echinococcus is transmitted is through something called a predator-prey association, where it grows within both the predator, which in this case is dogs typically, but the canid family, which includes animals like foxes and bobcats. And then it also grows within the prey, in this case, herbivorous prey, or classically in sheep. And so the way it works is the dogs or the canids function as the definitive host. And so in definitive host, sexual reproduction occurs. So Echinococcus will reproduce sexually, where it forms the adult worm inside the intestine and produces eggs. These eggs are then released to the environment via feces. And then in the intermediate host, which in this case is an herbivorous prey, classically sheep, there's growth, but there's no sexual reproduction. And so in this inside the sheep, the sheep will ingest the egg and then transform into an oncospore and then travel into the typically the liver, but like I said earlier, it could be the bone, the brain, anywhere. And then ultimately it will grow into a form called the protoscolocy, which then will eventually be eaten by the dog, and the cycle kind of repeats. Um, and then oftentimes when humans they interact with the dog and then ingest the egg, and then we function as intermediate hosts as well. And so the epidemiology, where do we find Echinococcus? Typically, it's throughout the world. If you look at this map on the right, the deeper reds, it's more endemic, but it's found just about everywhere outside of, the United States. It is found in Alaska, but it's most prevalent in, as we can see, South America, the Mediterranean, Eastern Africa, Central Asia, and then specifically talking about South America, because that's more related to our case. There's about 5,000 new cases which are diagnosed every year. The main countries where it's most prevalent are in Argentina, Bolivia, Brazil, and Chile, as well as a few others. And when I'm talking about countries, and that's how it's typically reported as the country as a whole. But you're most likely going to encounter hydatid cysts and echinococcus, and sheep farming villages or villages outside of cities. So you're not necessarily going to see it or be at risk if you're in a place like Buenos Aires. The risk factors for contracting hydatid cysts are contact with dogs and raising livestock. And so on to our case. So in this case, we have three different teams of physicians. There's the emergency department, the general surgery, trauma surgery team, which is where the team I was on, and then as well as the GI, the gastroenterologist. And so on day zero, this is before the patient ever made their way to the surgery team. The patient presented to the emergency room where it was a 31-year-old male with a past medical history of H. pylori, presenting for 3 days of epigastric pain. He said it's exactly like his prior H. pylori episodes, which have been treated in Argentina, in Bolivia, with just triple antibiotic therapy. And on exam, the patient had some epigastric pain or epigastric tenderness, but I guess through shared decision making with the patient and with the physician, they opted not to perform any workup, no labs, no imaging, and just discharge the patient on triple antibiotic therapy, which I feel like that's kind of interesting. You don't hear that a lot, someone going into the ER and not receiving any lab work or anything. But honestly, I think it is a decent utilization of resources. I guess ultimately it didn't, work out as we'll talk because the next day the patient returned to the ER with worsening abdominal pain, nausea and vomiting. And he was unable to tolerate anything by mouth. And so this time the physician did order labs and imaging. And on the labs, what we'll see is that there's the bilirubin, the AST, the ALT, and the ALP are all elevated. This is suggesting a liver pathology, as well as with an elevated bilirubin, maybe some sort of blockage in the biliary tree. And then the lipase was normal at 99, which says this is probably more proximal to the pancreas. The urinalysis kind of helps support the laboratory findings. They performed a CAT scan of the abdomen and pelvis with contrast, and there you see they saw some fluid around the gallbladder, which was kind of consistent or concerning for cholecystitis, as well as some intrahepatic bile duct dilatation, once again, supportive of a cholecystitis or maybe some kind of blockage. But also in the gallbladder fossa, so pretty much where the gallbladder sits on the liver, they saw this bilobed 4.5 centimeter rim enhancing cystic lesion, which the radiologists report as either being an abscess or another hepatic lesion. And so because of these findings and the patient's, status, he was admitted and started on broad spectrum antibiotics. And so here's some imaging. This is from Radiopedia. It's not the patient, but should just about be, it's consistent with his presentation. So here it's the CT abdomen and pelvis axial view. We have the liver here, which is this brighter area or less dense. Surrounding here is the gallbladder. You can see kind of this circling, encasement. That's the wall of the gallbladder. And then just surrounding it, you see this area of lower density for fluid. So this is what was reported on our CAT scan, the pericholecystic fluid. And here, this patient likely has a large gallstone. And then this is a different patient, but the one we'll be looking at for the next three images of biliary tract dilatation. You just see this lower density fluid in the bile duct. So here on this other patient, you can't really see it, but right here is what we're looking at. And then a few more images. So this is the same patient as the last image I just showed, but this patient had a hepatic abscess. And so here, once again, we're looking at the liver. This is in a coronal view, but what you can see here is a abscess, and what's different, what would have been different on our patient was you would have had more of a concentric ring, but here you can see the outlines of an abscess, this lower density area, and then it kind of leads off into a tract, which you can see connects to the gallbladder here. So this patient here has an abscess that's communicating with the gallbladder, which is similar to what we'll see our patient had with his hydatid cyst connecting to the gallbladder. All right. And so I guess that was a lot of recap, but it's just we had imaging showing cholecystitis and a cyst, which was uh, consistent with some of our exam findings. And day 2 in the hospital, the GI team performed a ERCP. So they stuck the scope down his upper GI tract, and there they removed a stone in the biliary tree. So there's some choledochal lithiasis, as well as they performed a sphincterotomy. So they opened up the sphincter of Oddi right here. You can see the gallbladder and the biliary tree connecting into the duodenum. So there was a stone somewhere about here. Then they opened up uh, the sphincter, and the pancreas was not involved. And then, so after the stone removal, as well as with the broad spectrum antibiotics, we were starting to see his laboratory findings kind of normalize. So things were settling down. They all decreased. The lipase stayed the same. And which is, like I said earlier, the pancreas wasn't necessarily involved. And so day 3, this is where the surgery team and myself come in. We plan to have a cholecystectomy, and so we removed the gallbladder. It was moderately distended, friable, pretty much was fairly straightforward. Worth noting, it was about I guess I've seen 50 plus so cholecystectomies in my days, and this was definitely the most irritated, friable gallbladder I encountered. And then then after we removed that, we turned our attention to the cyst, and so ultimately we used a laparoscopic needle aspirator to pierce the structure, and we sent the cyst for cytology. And then at that time, we also biopsied the wall, and what we removed were these white membranous septations, and we sent those to pathology. It certainly wasn't what we were expecting. We didn't know what we were looking at. I had fortunately done some reading or UWorld questions about Hydatid cyst, so I mentioned it at the time, and that was kind of dismissed by the team, which, to be fair, is a bit of a rare finding. But we also saw some gallstones as well in there, which kind of, like I said, suggests a communication between the gallbladder and the hydatid cyst. And so here, when we have another schematic of the liver and gallbladder, and and then I place this yellow circle to just indicate the proximity of the gallbladder to the cyst. They're right next to each other. And then just in it during the procedure with the possible communication, there was some concern for a biliary tree leak, so we left a surgical drain. And here are some images from the surgery. And so here you see a suction device, and then, but to the right of that, or well, entering into the cyst, and then here's the cyst wall. We have already removed the septations from inside the cyst, as well as the gallstones, but they're present in there. To the right, you see this congealed blood, and that is where the gallbladder had previously been sitting before we removed it. And just to hammer home the point, what we found inside the cyst was what I liken the most to. It was like looking at modeled snake skin, and so we and so it was like we were pulling out snake skin from inside of the cyst, as well as there were some some gallstones. And day 4, post-op, we performed a Hydascan for concern with the bile leak, which was confirmed via the Hydascan. So the GI team put a stent inside the common bile duct just to take care of that. And then day 5 was discharge. We received the pathology report, which showed protoscolices consistent with hydatid cyst. So it was kind of the talk of the hospital that we had this pretty rare finding that no one had necessarily seen before, and one we weren't totally expecting. We did a literature review and placed the patient on albendazole 200 milligrams twice daily for 30 days. And then ultimately, several days later, removed the peritoneal drain, as well as a month later, the GI team removed the biliary stent. And so some discussion. The first question is where did the patient contract the echinococcus? Of course, we're in Kansas, and so that's where we first, researched to see could it have come from here. We're in eastern Kansas in Overland Park, and a lot of the data about echinococcus in Kansas in the U.S. is pretty scarce. It's not reported to the CDC. It's underdiagnosed because, physicians aren't really looking for it because it's not endemic. And most of the data is limited to case reports. In Kansas, findings of echinococcus, it is present inside canids, which include wild canids, red foxes, coyotes, and bobcats. Not necessarily domesticated dogs. There are no case reports in Kansas of humans presenting with hydatid cyst, which is what makes our finding notable. And then in Missouri, there just to our neighbor to the east, of course, in Missouri, there's a case report of a 6-year-old female presenting with hydatid cyst. It's thought she contracted it in Alaska, where it's endemic. And then, as well as a domestic dog, had a case of echinococcus multilocularis. So, not exactly the same thing as our hydatid cyst, but definitely closely related. So it begs the question, where was our patient infected? It's endemic. Hydatid cysts are endemic to Argentina and Bolivia, where he travels frequently. So most likely from there, as well as he also likely did not get it in Buenos Aires. It was more likely in a farming village he visited at some point. And so we believe or hypothesize that there was some form of cyst, gallbladder, fistula, just based on the bile stones inside of the hydatid cyst that we noted. And so there have been case reports of that in the past as well, where they were able to see it more explicitly. And also, it wasn't apparent upon inspection. So maybe there was a fistula at one point that allowed the bile stones to be there. And so in the future, when you're diagnosing a hydatid cyst, of course, you want to diagnose it before you're in the middle of a surgery. And so first and foremost, you need to add it to the differential. Just because we're in Kansas or Missouri doesn't mean we shouldn't be prepared to see this, especially in a patient who we were aware of his South American travel history. And so you can diagnose it radiographically using ultrasound, CAT scan, MRI, or X-ray. And so and this is an ultrasound down here, but it first presents as a cystic lesion. And then throughout its lifespan, it grows from a CE1 to CE5. Those are just, they each have different radiographic findings, but here in CE2, cystic echinococcus 2, you see the septations. And most of the time when it presents, you'll either find the hydatid cyst incidentally or through mass effect of adjacent structures. So it could block the biliary tree. It could cause a small bowel obstruction or inferior vena cava syndrome, very variable. And then you can also aspirate the fluid and send it to pathology for diagnosis. So, in the treatment indications for hydatid cyst, there are three. If you see a slowly growing or static cystic mass on imaging, if the patient experiences anaphylaxis due to rupture or leaking of the cyst, or three, an incidental finding of cyst and then asymptomatic carrier, and so since we found I don't know, since we found the cyst, it was indicated to be removed during the surgery. And there are three treatment options. There have been no clinical trials to compare their efficacy. One is you can do surgery. Two, you can do something called PAIR or puncture aspiration, injection reaspiration, or medication to treat hydatid cysts. With surgery, the indications are going to depend on the cyst location, the natural history of it. So if it's close to the vena cava, maybe it might be better to treat it with medication. But as well as resources, like I said, this often occurs in farming villages in Argentina. So surgery is, of course, a resource intense operation. The benefit of surgery is its definitive treatment and cure with a low rate of dissemination of the echinococcus into the abdomen as well as relapse. And of course, surgery is a risk as well. So puncture, aspiration, injection, reaspiration is another way to treat it. In America, it would likely be done by an interventional radiologist. So you use an ultrasound in order to puncture the cyst, and you do this percutaneously, and then aspirate the cyst fluid to confirm pathology. You can send it for pathology then and there, and then you would inject protoscolicide to kill the echinococcus. You wait 10 to 15 minutes, you reaspirate the cyst content, and then you reaspirate the cyst content. So you're removing parasitic material from the cyst, so that's a benefit as well. And then also with medications, they're treated with benzimidazoles. You can do monotherapy. Albendazole is preferred. You can use it as adjunctive therapy as well, which we opted to do. And when we gave the patient albendazole 200 milligram twice daily for 30 days. The caveat to this, as we can see with GoodRx, is the retail price is about $12,000 or $13,000. It looks like Mark Cuban over at GoodRx can get you a good deal for $115. But it was definitely something we had to investigate with our patient and involve the insurance companies to cover. In conclusion, hydatid cysts are caused by Echinococcus granulosus. 75% are found in the liver. There's worldwide prevalence outside of the US, primarily South America, the Mediterranean, China, East Africa, as well as Alaska. And it should be on the differential of a patient with a liver cyst and international travel history. The treatment modalities include PAIR, surgery, and albendazole. And here are my references. And are there any questions?